Well, welcome everyone. Welcome to another ForceNet webinar. My name is Chad Cook, and I'll be the moderator for today's webinar, and along with Bill Reed, who is the other principal investigator of ForceNet. We're very excited that you selected this particular webinar. Let's talk about some rules before we get started. I see that a lot of you have attended previously. What we do is we keep everybody on mute throughout. It's much less distracting for our speaker, and it allows you to put your questions in the chat room. I'll function as the moderator. I'll select the questions, we'll pitch them to our speaker, and then he can answer the questions after he has a formal presentation. Today's speaker is a very good one, and it's one that we actually have had several people request. This is Dr. Jorge Esteves, and he is an osteopath with over 30 years of clinical experience. He's currently a professor of osteopathy at Atlantica University in Portugal. He has worked both as a clinician and an academic in several countries, including the UK, the UAE, Saudi Arabia, Italy, Malta, and Portugal. And we were chatting just prior to popping on. He actually speaks 5 different languages, and it could be 6, but he's not giving himself credit for one of the languages. So his research interests focus on the role of Bayesian brain generative models, including active inference in musculoskeletal care, particularly in patients living with chronic pain, as well as the broader role of touch in manual therapy. And I'm quite certain you're probably on because you've read some of his work or have heard him present on this before. And I have had the luxury of actually presenting at the same conference as Dr. Esteves. He is a great speaker. He is the type of speaker you do not want to follow at a conference. And I think you'll be very pleased. George, welcome to this ForceNet webinar. We'll turn it over to you.
Thank you, Chad. Thank you very much for the invitation. And I look forward to your interactions at the end with me. So I'll start by sharing my screen. Okay. Wait. Bear with me. Almost there. Okay. So what we're going to talk about today is more than just touch. So it's looking into touch from a person-centered perspective, and sort of from the Therapeutic Alliance to the manual therapy outcomes, and try to understand touch from the perspective of not just the hands-on passive care, as sometimes we are accused of as manual therapists in general, but to try to understand that actually what is the role of that important form of communication in the process of care, and how we can help someone in front of us with a problem. So the first question is always that's about, it's about touch. And, we can go to very kind of sometimes very aggressive environments like Twitter, where people tend to accuse any form of manual therapy as passive care, something that doesn't make any sense, something that, should be completely ruled out from modern healthcare practice, in particular in the field of musculoskeletal care. So one can think about, manual therapy, and one thinks about the hand, and a lot of times we tend to think about manual therapy from that passive perspective, from that sort of applying technique, from that perspective of kind of changing something. And for a long time, manual therapy, and I come from the field of osteopathy, and for me, I don't see osteopathy as manual therapy per se, but of course, manual therapy is our approach, is our therapeutic intervention, pretty much. So from that perspective, and from the broader field of manual therapy, we have been for a long time kind of grounded on this biomechanical paradigm, assuming kind of that pain arises from structural dysfunctions. And for a long time, this idea that, one finds stuff and fixes something. So it's about sort of having a clever hand through a very well-developed sense of palpation, as one tends to argue, because it takes so many years to become such, a good practitioner that is able to palpate and find everything and then fix everything. So for a long time, that has been the sort of the link between manual therapy and this sort of biomedical model, primarily this biomechanical paradigm of trying to find things. But of course, things have changed, and we struggle to find reasonable evidence suggesting that actually manual therapy alone can help with complex situations, particularly those patients with complex pain presentations, which tend to represent a lot of our kind of practice as musculoskeletal practitioners. So if one thinks about the hand and moves away from that very reductionist paradigm of trying to find something and fix something, one should start thinking about the hand from a different perspective. And the argument is that the hand is not just a tool, is an extension of the perceptual and cognitive system of the practitioner, facilitates sensory integration and affective attunement, acts as a channel for prediction error signaling. So thinking about already that the patient in front of you is a sort of a predictive machine. Largely, the nervous system works very much as that predictive machine, and therefore, touch, hands, does provide that sort of input, that channel for prediction error signaling, enables real-time negotiation of safety, agency, and meaning. And the hand does not do, alone. It listens, it modulates, it responds. So one thinks about that from that perspective. The hand is, of course, central to delivering care, but it's not just about the technique. It's not just about the effects of the technique and the wonderful sort of technical kind of ability of a practitioner that differentiates that practitioner from everybody else. Now, the hand plays a much broader role, and it is, goes well beyond the structural correction, the kind of, the correction of dysfunction, to consider that actually touch becomes a vehicle for, the hand becomes a vehicle for touch, and that affects perception, safety, identity. Aya Lederman a few years ago proposed that actually in the field of osteopathy, the osteopathic manual therapy techniques should be very much viewed as a vehicle to deliver touch effects that would have positive influence on the sense of self, well-being, and body image. So it's much more than really that very reductionist model of finding the dysfunction and treating that dysfunction. So touch becomes a therapeutic signal, is about grounding, is about orienting, is about meaning, pretty much. So if we think from that perspective, of course, we need to start thinking about reframing manual therapy. And I know that there's several people, including people that are here today on the ForceNet group, that have been publishing very interesting papers pretty much from this perspective, the perspective that we should reframe manual therapy from a person-centered perspective. So it's well beyond the tissue change. It's about sort of touching as an interface for meaning making, not correction, not sort of fixing dysfunctions. Manual therapy is context sensitive, so which is shaped by the patient's story, the expectations, the relational cues. So very much important to think here about the role of contextual factors that cannot be separated from that hands-on kind of intervention. Is about co-regulation. So, the aspect of synchrony between a practitioner and the patient. So the sort of, and I will talk about that later, the idea that in an ecological niche, in a dyadic relationship, two become one, and it kind of, becomes a duet for one. And the therapist becomes very much a guide. Therapy is guidance, is not, just as a practitioner, as a technician. So this is work that has been going on now for approximately 5 years. It's a developing framework. We have published several papers that have been, initially kind of hypothesis driven, try to sort of go outside the field of manual therapy, primarily to the field of enactivism and active inference, Bayesian brain frameworks, and try to bring some kind of ideas that can be used, to understand broadly what we do as practitioners, as musculoskeletal practitioners. So the roadmap for this talk, and it's a long talk, but I'll try to sort of skip on some aspects during the slides, try to get some time to the end so we can have some, a meaningful dialogue. So this is the roadmap. So starting from the perspective of person-centered care and therapeutic alliance, then thinking about beyond the biopsychosocial model, and here introducing the concepts of active inference, predictive processing in general, and enactivism, and then go through touch, primarily through affective touch, and then try to put some of the ideas together in a way that we can kind of inform our practice and kind of move forward if we want, of course. This is arguably a proposal. It's not, it's not something that, of course, should be, used without a good level of critical appraisal. So we start from this idea that person-centered care. So it became very much a sexy thing these days. Everybody sort of claims to be delivering person-centered care, where in fact, I see from a lot of practitioners and a lot of colleagues that what actually do is practitioner-centered care. They decide what's best for the patient, and then based on that model, they provide that care. So the person, a lot of times is a passive recipient of care rather than actually being someone at the center of the intervention and someone that has a voice and has, expectations, has needs. And it is fundamental that we understand what they are. So person-centered care, there is, good evidence that person-centered care provides, good outcomes. It's essential, promotes shared attention and cooperative communication, enhances patient engagement, satisfaction, and the outcomes in musculoskeletal conditions. And of course, that person-centered care is tailored to the individual needs and preferences, and therefore builds the confidence, the trust, and a robust therapeutic alliance. So the idea, of thinking about person-centered care, and already kind of it touched upon the idea of a therapeutic alliance. Therapeutic alliance becomes a very important part of that process of care. Now, if we go a little bit back and try to understand the person in front of us, and this has implications in terms of models of care from sort of the shift from the biomedical model to the biopsychosocial model, to other models of care that exist in the various professions, but largely one could argue within those kind of that dichotomy between biomedical or biopsychosocial. It is important to understand the person, and the person, of course, is not just a body. And sometimes we forget about that. And actually, it reminds me sometimes interactions, discussions I have with students that say, well, the patient presents with this condition that has got neck pain, has got this problem with the neck or the back or so on. And I tend to ask them, okay, fine. So that's the body, but there is a person that lives inside that body. And, what does, and sometimes people look a little bit gobsmacked about what I'm talking about, but arguably we have a body, and our sense of self exists. It's largely it's a central nervous system, is a brain-based kind of model, and arises primarily because we have a body. So the body still plays a very important role, but the sense of self is a very complex, multi-level perception. And for those of you that actually want to sort of go a little bit further and try to understand a little bit about, for example, the sense of self and chronic pain conditions, there is a very good paper recently published by Peter Stilwell and colleagues, which is a phenomenological study looking at the effect of chronic pain, so pain as suffering, where they go through the ideas of a minimal self and the narrative self, and what does chronic pain actually cause to that part of an individual. So this representation here from one of our papers, but actually based on Anil Seth work, and it kind of gives an idea about what is the self. And of course, we have the embodied self. Having a body is fundamental. I said that, our sense of self is largely constructed through our living bodies. So that's still very important. And I just mentioned the idea of a narrative self. And a narrative self, we know, particularly from our kind of chronic pain conditions, chronic pain patients, when we ask them, for example, tell me a little bit about your story, that idea of, tell me about your story comes a long kind of, a long story pretty much, but a sort of, a story that gives us a very good insight, into their life as individuals. Linked to that narrative self and the embodied self comes another very important aspect that we tend to see that becomes affected primarily with chronic pain conditions, which is the volitional self, or also known as the sense of agency. So the patient bringing a chronic pain patient, for example, means someone that has lost the agency, the ability to do, what matters to them, the activities of daily living, for example. And there are other parts of the self that are important, including the social and the perspectival self. So the self is this kind of really multi-level sort of construct. And this is, from the field of osteopathy, is a very nice sort of description of the body as the primary machinery of life from our Irvin Kerr from 1970, where Kerr, that was a very influential physiologist in the field of osteopathy, very much described that life is not a composite of functions of the viscera, of the physiology, of the anatomy, of the structure, and so on. And sometimes, again, we tend to forget a little bit about that. We're dealing with someone that is not just the anatomy, the physiology is not just structure and function, but actually what Kerr argued was that a man moves, runs, works, plays tennis, builds buildings, paints pictures, makes music, love, and war. And he does also practice medicine and does, gives osteopathic manipulations. So here, there's a sort of a moving away from the idea that, we are talking primarily about structure and function to talk about this sense of agency. So a man is someone, we do something that is meaningful to us, something that makes sense to us, something that we want to do. And what happens when, the body becomes dysfunctional with pain and other kind of ailments, they tend to become the center of attention, and the patient comes to see us for some treatment. And a lot of times the treatment they expect is a manual form of treatment, something that fixes the body. But, one needs to think about, go beyond this idea of just the structure and function to actually think about, the idea of agency, of something that makes sense to that person. So if you're thinking about that, and I know that if we go on to the sense of self and some of these ideas, we have the risk of going very deeply into the philosophical world, which is a fundamental part to also understand, the process of care. But we need to think about, the self is an emergent relational process. It's not something that is crystallized, is fixed. So selfhood is not that static entity. It's an evolving goal-directed process shaped by lived experience. And the goal-directed process here very much illustrates that sense of agency, the ability of doing what matters. So, of course, if you're thinking about, an elderly patient that, is stuck at home because, let's say does have a very poor hip and cannot walk, is scared of going out, lost the friendships because, is stuck at home and so on, recovering the sense of agency, doing minimal things that could enable the person to start perhaps going out and go shopping, that could have a very important impact in the whole person, including the social aspects of that self, including also in terms of their mental health. So the selfhood is very much this goal-directed process. It's co-constructed through interactions with the world and with people around us. So it does not stop with a person, it does sort of move beyond that. So that's also when one thinks about purely from a biopsychosocial and thinks about, okay, is either bio or psychosocial, sometimes forgets about the sort of the interacting world around them. And actually those interactions, mean a lot in this sort of process. Consciousness is embodied. Again, the self is not confined to the brain because otherwise we risk becoming brain-centric. And we saw that, a few years ago with the advent of, pain neuroscience education, where, and including myself, ended up sort of giving lectures on patients about the neuroscience of pain, for example. And after 10 minutes, a lot of them sort of looked at us and sort of, I don't know what you're talking about, but it looks like, you're talking about something in my head. So it's not just confined to the brain. So consciousness is very much that dynamic coupling between brain or nervous system. One should think about not just the brain, but actually think broadly about the nervous system, the body, and the environment. So that, of course, this challenges very much that Cartesian dualism and proposes to start holistic perspective of cognition that is grounded in both the biology and also the social engagement. And here, and one of my arguments when talks about the biopsychosocial and the biopsychosocial, the argument is actually the psychosocial is also biological. So, it's not just we can sort of compartmentalize everything in, those three main categories. And of course, actually on the BPS, and we'll go through that in a second, on the BPS has been heavily criticized over the last few years. And this is a very nice paper from Ben Cormack and colleagues published in 2022, where they sort of challenged the biopsychosocial model, and they proposed an extension to the inactive aspect of that biopsychosocial, so proposing a kind of a inactive biopsychosocial perspective on patient care, and arguing that without a humanistic approach involving the person and the relationship, that is person and relationship centeredness, is very difficult to provide good quality care and contribute to positive outcomes, and sort of outcomes that can be extended in long periods of time. So with this, if you're thinking about the self, when we start thinking about already the sort of interactions with the environments, already mentioned some ideas about, the nervous system being a predictive machine, one thing is fundamental is to start thinking about, we need to understand the person seeking care, the person that is in front of you. And rather than sometimes, you're asking a lot of the questions about where is your pain, what makes it worse and better and so on, despite being fundamental in a lot of cases, is also very important to understand really the patient's story. What brings you here? What's your story? And this is actually something that you find, for example, in the work of Peter Sullivan in cognitive functional therapy, where there's that sort of a emphasis on the patient's story. So understanding the person seeking care is, in my perspective, a fundamental part of the jigsaw as a very important starting point. And of course, if we start from that perspective, we are starting to think about the idea of developing an alliance with the patient. And of course, we all know that it is extremely difficult to have good alliances with every single patient that comes through the door. Doesn't happen. Life doesn't happen. It's just a fact of life. We don't get on well with everybody around us. There's some people, our approach suits them best, and the vice versa. Some patients, it don't seem to click. But arguably, we should sort of really aim to develop a good relationship with our patients, have a strong alliance, and it is a sort of it's a critical aspect of person-centered care. Without that kind of strong alliance, one can argue that there's not really a person-centered care approach. Is as I said before, arguably more of a sort of a practitioner-centered approach. So the strong alliance, we know from research, that contributes to improve outcomes and satisfaction, pain reduction, and so on. And an important thing here as part of that alliance is this idea of an affective attunement and shared understanding. So it's about recognizing and aligning our own beliefs with their own beliefs, expectations, and embodied priors. And what I mean by embodied priors, a lot of this is not just a sort of verbal communication. A lot of this, we get through by observing the patient. We get through by kind of, sometimes pointing to, you're telling me one story, but in fact, your body's telling me something else. The idea, for example, of kinesiophobia, the patient may well say, no, I'm okay, but actually when you ask them to kind of, for example, do some kind of movement, there is something kind of freezes. So there's a sort of a prior there that may not be to the level of being verbalized, but is actually embodied. So it's important to understand that. And of course, this is achieved largely through cooperative communication, safety, mutual trust, and this idea that, a strong therapeutic alliance is associated with epistemic trust. So where people, we sort of end up sharing knowledge with our patients, and through that process, the patient becomes much more willing to open up, to say what really concerns them, even if they think that's not entirely appropriate to bring to the table in this particular context. But what, I'll mention it anyway, to the kind of, feeling safe. So therapeutic alliance, really a strong component of this person-centered care. So a building block that we sort of putting here towards the sort of understanding really where touch then, fits. So developing the therapeutic alliance, it's something that requires adaptation. It requires this mutual adaptation because we need to sort of understand the other person. The other person needs to understand us. We need to sort of align our expectations, our priors with their own priors and expectations. So this is achieved, through shared attention, trust, flexible communication. And one can argue is formulated through this active inference perspective. And we'll come to that in a second, but the idea that, we, from an active inference perspective, we anticipate the consequences of actions, and therefore we already start acting on something that we believe is going to sort of be good, bad, or have an impact on, on our situation, on our condition, and, what we want to achieve. So where does touch really fit? Now, the argument we put forward, a couple of years ago with 3 papers on touch and therapeutic alliance as active inference, we proposed that actually touch becomes a very important part of the development of that therapeutic alliance. So touch is not that, actually going back to the beginning, the hand touch, not just a sort of something to deliver care from a perspective of fixing dysfunction, but touch as a catalyst for therapeutic alliance. So the hands-on care conveys more than the biomechanics, communicates intent, empathy, safety, anchors interpersonal synchrony and attunement. So also enables clinicians to infer and respond to the patient's mental, affective state. So this shifts away from the idea that, osteos, physios, chiropractors have this sort of super developed sense of palpation that they can diagnose anything that moves and doesn't move, and to the point that actually touch or palpation is much more than that kind of, doorbell ringing kind of approach. I find the dysfunction. It is here to actually think about that actually through touch, through the hands-on care, we actually start understanding what's going on, inferring what's going on with the patient's mental and affective state. We can feel things at times. The patient says, I'm okay, but actually when you palpate something, when we touch them, we feel completely freezing state. They seem to be scared of something. So it is important to go beyond and think about, the touch really as a critical aspect of, the building of a therapeutic alliance, and therefore can be framed through this active inference perspective, which is about, providing sensory precision that minimizes prediction errors and ultimately a model that exists in that individual. So going beyond the biopsychosocial model. So, one thing that is, I always find fascinating is that, a lot of practitioners seem to have just discovered the biopsychosocial model. Something that, the new kid on the block is the biopsychosocial model. As funny enough, was developed by Engel in 1977. So long time ago. So it's not new. It's not a new kid on the block anyway. And was developed in the field of psychiatry. That's a field that very much shares the same sort of dilemmas that musculoskeletal care has, which is the complexity of understanding a person with a problem. So how do I treat depression, for example? Some psychiatrists may treat the brain, may give medication. Others may go to a sort of a combination of medication and talking therapy. Others may just do the kind of talking therapy. So it's a sort of changes a lot. And evidence-based practice became quite a difficult thing. So Engel developed a model to understand the person in front of him as a clinician and try to provide best care. But then, like many other things, the biopsychosocial model became biomedicalized, like Cormack and colleagues argued, and very much became separated in these 3 dimensions, with a lot of manual therapists saying, well, I'm not a psychologist, and therefore I don't care about the psychosocial aspect. I'm very interested in the bio. But, again, going back to my argument and the argument that I share with other colleagues is the psychosocial is also bio. So, clearly one cannot just kind of, separate things that way. And the analogy, of the self of a patient in front of you is of this very nice cake, where is a sort of a multi-layered kind of cake, and there's so many layers that interact and so many layers that tend to influence outcomes. So it's important to not just get stuck in something that seems to be either one thing or another, but to try to understand the person more broadly. And understanding the person's experience, the person that is in front of you, requires an understanding that actually what happens is it's a person with a predictive machine, with a predictive brain that arguably very much builds their own sort of reality. And some authors have argued that, in fact, what happens is we live in a state of controlled hallucination. I don't entirely agree with that description, but that's a description to sort of tends to illustrate that each one of us has our own sort of constructions of the world. So each one of us has our own sort of predictions about, what we expect when we're in front of a practitioner, what we expect with the problem we have, what worries us, and so on. So how to interpret the facial expression to the kind of the feelings of pain. And Andy Clark puts that very nicely in his book in 2023. So the idea that really one needs to understand the person, and one needs to understand that that person has got, built in a nervous system that was not designed arguably for cognition, but was designed largely to sort of keep us alive and, the business of survival. So it's a nervous system that operates as this predictive machine. So anticipates consequences of actions, has got some calibrations built in, and therefore anything that is sort of, any input, a lot of times is faced with a prior that might just kind of override completely that sensory input, and having something that is sort of, doesn't change at all because my expectations of this movement is pain. Therefore, before I start moving, I'm already in pain. So, when we say that, well, the pain is in your mind, sometimes it is from that perspective. So active expectations of pain or relief shape the entire experiential web, as Clark describes. And of course, these active expectations of pain or relief are associated with the broad concepts of placebo or nocebo. And in fact, there is, recent work looking into nocebo and placebo from this active inference or from a predictive processing perspective, trying to understand that actually that's a process of inference in a lot of times. So therefore, what the interventions do, what the therapeutic interventions do, they tend to sort of perturb, the bodily prediction errors. So introduce novelty, introduce sensory input that can recalibrate maladaptive models, and, for example, in the context of chronic pain, also improve pain. So with that, and take us to, to understand a little bit more of the sort of theoretical framework, one question that is important to think about straight away is, how do living organisms, and here we're not talking about just humans, we're talking about any living organism, how do they persist whilst engaging in adaptive changes with the environment? And they do this by adapting and coupling with and adapting to the environment. So the concept of adaptation is a critical aspect to understand if we try to understand things, if we try to understand person-centered care via a sort of inactivist or active inference perspective. One needs to understand the broader concept of adaptation, and in a lot of cases, the concept of maladaptation. Why does someone actually fail to adapt? Because if every single organism has the ability to adapt, what happens when those adaptations stop functioning, when something becomes kind of maladaptive? So adaptation is seen as a survival strategy, and adaptation is closely associated with the concept of resilience. So adaptation as a survival strategy and resilience go together. Adaptation is experience driven. So it's about the interaction with the environment. It's about interactions with the environment in the business of achieving what matters to that organism. In the case of us, for example, in the business of agency, in the business of doing something that really matters to us as individuals, from our activities of daily living to playing sport, to go to work, to our family relationships, to friends, and so on and so forth. that is part of that adaptation, requires a strong and well-functioning agency. And in some cases, what happens when that adaptation fails, we tend to see aspects of rigidity building in and linking to, for example, aspects of psychopathology. For example, in some cases of depression, what we see is patients lose the cognitive flexibility and become stuck in maladaptive thought and behavioral loops. And if we move away from depression, mental health, and actually move that towards persistent pain, for example, we tend to find similar things. But in fact, sometimes depression and chronic pain go together, as we know, but we tend to identify also those sort of maladaptive sort of behaviors, patients that seem to be stuck in those kind of, models. Now, if we're thinking about this sort of adaptation, if we're thinking about organisms and the environments, that takes us to one of the most complex things to understand that kind of informs a lot of the work on active inference, which is the principle of, the free energy principle developed by Carl Friston. So the free energy principle, coming from physics and then neuroscience, primarily computational neuroscience, tends to explain how adaptive, dynamic adaptive systems maintain their order. And the order here means this non-equilibrium steady state. And, times we tend to think about, okay, if we're thinking about homeostasis, we're thinking about equilibrium. Now, in fact, equilibrium is entropy, is zero, is, I've gone from the planet. That's equilibrium from a physics perspective. So we maintain, as organisms, we maintain ourselves in this sort of non-equilibrium steady state, which is in fact what homeostasis is, because homeostasis is the constant fluctuations going on within the system. So we maintain ourselves in that sort of non-equilibrium steady state by limiting ourselves to a number of states that challenge entropy. So organisms tend to avoid something that brings this idea of surprise, the idea of surprise here that can increase the entropic state and therefore potentially be lethal for that organism. So what that means from a clinical perspective means that, and a lot of times our patients tend to mitigate unpredicted sensations. They know and they anticipate what the consequences of some actions or the consequences of some sensations are, and they tend to get stuck themselves in a state that basically prevents entropy, protects them. And that's, in a nutshell, what the free energy principle is about sort of minimizing free energy, is about staying in a number of states that becomes sort of positive and important to prevent entropy on an organism. Building from that, there's a development of the idea of active inference. And what active inference, again, in a nutshell, means is we tend to anticipate the consequences of actions, and therefore we're not just passive recipients waiting for an input to figure out what that input means and then change our mind. What happens is we tend to actively sample the world and change that world in a way that fits our own model. So the idea here is a sort of an inversion of the sense, think, act, the sort of the old idea of sensation and perception, sensation, bottom-up physiology, something comes through your visual system or through your, haptic system and goes up to the brain, and in the brain is sort of interpret, and then there's a top-down signal and so on. So it's an inversion of that sense, think, act, sensation, perception to a constant action perception loop. So what happens is all the time we act on the world, we change the world in a way that fits our model. And that is a fundamental thing to free energy minimization, because what we tend to do is we tend to act on the world to fit our model to, again, reduce entropy and to stay within the boundaries of what we think is safe to our system. So that's a sort of, again, try to sort of make some sense of what that means in terms of active inference. Active inference, this idea that is about action perception loops, and is not just sort of, really having an input, think about what this means, top-down signal, and that, act. No, it's a constant process. I act, I perceive, I act, and I perceive. And it's this constant loop that is fundamental aspect to understand, and fundamental to understand in this process of care. So it's associated with this idea of the sensory motor coupling. So the idea that to feel is to palpate, to see is to look, to see when we look at something, of course, our visual system is an active inference system. The saccadic movements are exactly that. The saccadic movements of the eye are clearly sampling the environment, are foraging for information that tends to sort of fit, tends to give a perception of what's going on. So that sort of visual system is something that actually easy to understand, really, what an active inference system is. The other system that is an active inference system is the interoceptive system. The information that comes through our viscera, for example, already has got some kind of built-in model, and the sensations come in are faced with, a prior, something that, sort of anticipates what that input means, and through that, there's already some action taking place. So again, if you're thinking about homeostasis or allostasis, moving slightly away outside that sort of, steady state to a state of sort of slightly pushing a little bit to the limits, is exactly that. So the systems adapt and respond to the environment, anticipate what's going on, and they already put in more in action all the necessary actions to sort of anticipate what will happen. So we actively create sensations, and a critical aspect of the active inference is embodied. So we need to have a body really to sort of change outcomes, to act on the world, to try and understand, what's going on. Sorry, the other way around. So if we interact with the world and we have this built-in system, let's go back one. If we have this built-in system that interacts with the world, does it mean that the system is part of the world? No, it's not. There is always a separation between the world around us and the system itself. And in the active inference world, in the sort of free energy principle world, people talk about Markov blankets. And Markov blankets are kind of statistical sort of models, but Markov blankets tend to illustrate that separation. So we all know that, two cells have a Markov blanket. There's a separation between two cells. Different systems have Markov blankets. For example, if you're thinking about the interaction between the neuroendocrine immune system, so the interaction between those three systems have Markov blankets that allow for those interactions. The body is arguably a multi-nested Markov blanket. And within that multi-nested Markov blankets, there are interactions happen at so many levels, and those interactions will impact on the different systems and the different parts of the system. Two neurons have, also communicate through a Markov blanket. So the idea here is, if you think about that kind of, person with the world, with a Markov blanket that separates very much the active states, the internal states that have got active states, and the world around, so that is separated by that Markov blanket. There is a sort of something that enables us to communicate. When we put this together in the clinical world, we can think about actually in the clinical setting, imagine in a dyadic situation where you are with your patient. That means that we tend to sort of infer what's going on with the patient, and the patient tends to infer what's going on with us through that communication between the two systems. So it's difficult at times, and that's why, through the therapeutic alliance, through touch and so on, to understand that actually that communication enables us to infer what's going on and vice versa. Now, this is closely associated also with the concept of enactivism, although some people from the field of enactivism tend to kind of argue that different things. And probably some of you are familiar with the concept of inactive models of pain developed, for example, through PhD of Peter Stilwell, brilliant work, which is sort of, gone a little bit further on the biopsychosocial model. But again, from my perspective and perspective of other colleagues, when we talk about active inference in enactivism, we sort of talking about similar things. We're talking about the world interacting with the system. We're talking about the system that is not, it's cognition is not just about having a brain. Cognition is about having a body, is about action. So the 5 E's or the 4 E's of enactivism, including enactment and embodiment, are fundamental. So in the business of having a body that perceives and acts on the world, and enactment in terms of action. So things, again, linked to the idea that I talked about before, the idea of agency. And with those interactions with the world, comes this idea of affordance. And the affordances are opportunities for action. You probably, some may have seen, again, work of Peter Stilwell and Sabrina on that work, on the concept of affordances, or a paper by Vaz in 2023 on affordance-based clinical reasoning in musculoskeletal care. And the idea that the opportunities for action enable the patient to actually use the environment around to, for example, try new things, to sort of, for example, a patient that is struggling to walk, to use the opportunity because lives nearby a beautiful park to actually start, in a graded exposure perspective, try to sort of start exercising and so on. Now I go a little bit further on the concept of affordance here to actually, introduce the concept that actually in manual therapy, the interaction between you and your patient provides a field of affordances, opportunities for action that actually come through the interaction, both the verbal communication, but also the sort of hands-on intervention. So what is important to think about is a lot of times when you're interacting with your patient, is not just about fixing the dysfunction, it's about doing something very specific, but actually using the opportunities that interaction gives you, and the opportunity that the interaction gives you to actually change an outcome, to improve the situation on the patient, to improve the quality of care. So that idea that a patient here, an agent patient, has got the idea that is in front of you, there's something in the internal states that thinks about, I'm not sure about this sensation, I don't know what this means. So for example, danger in me or safety in me, the sort of the priors, what that means and so on, versus the solicitations, which are the kind of the manual therapy, the reassurance, the mindfulness-based intervention, the exercise and so on. From the osteopaths or the kind of manual therapy perspective, one can think about the interaction with the patient gives you opportunities to actually use that interaction to introduce new things, to kind of really create a situation where arguably in this ecological niche where you've got two systems, two agents with a Markov, with their own Markov blankets interacting, what you try to achieve is this idea that you achieve a do it for one. So you kind of try to synchronize with the individual in front of you. There's a sort of a sharing of information, shared attention, and so on. And that kind of, it's an important building block to actually effective care. So what about touch? Why does touch matters in this thing? At the end of the day, the talk is about touch, and so far we haven't talked that much about touch, or we haven't touched on touch. So what does touch really do? Overcomes uncertainty, is about repetition. So a lot of things about sort of it's about priming the system, it's about safety, it's about empathy, it's about synchrony, it's about salience. Think about two sides of touch. For those of you that may not be familiar with the two sides of touch, so we're all familiar with the discriminative touch, the kind of A beta fibers, the fast network and mechanoreceptors and so on, versus the other one, the slow touch, the unmyelinated fibers. And unmyelinated fibers here, also C fibers. I'm not talking about nociceptors, but I'm talking about the CT fibers. For those that may want to dive more into the whole business of discriminative versus affective touch, I would suggest you read this paper by Francis McGlone and colleagues. It's from 2014, but still a very good foundational paper to understand that. Within those two systems, there is this idea, this CT fiber, which are C fibers that are present in hairy skin, are not present in glabrous skin, and they support emotional, hormonal, and behavioral responses to skin contact. They're not just in humans, but actually we tend to find this in, a lot of other primates and other, rodents and so on. Even if we observe their behaviors, we see that they use touch as a way of social bonding, as a way of safety, as a way of emotional regulation. It's something, again, it's not just kind of, exclusive to humans, okay? It's a system that requires an integration of sensory pathways. So to provide this idea of affective touch, it requires the C-tactile fibers, but also requires the A-beta fibers. So it's the combination of both that kind of gives that idea of something that is pleasant, something that is affective. And it's something that, is contextually driven and provides context, provides safety, and so on. Now, the interesting thing about this form of touch, it uses the spinothalamic pathway because relies on C fibers and myelinated fibers like nociceptors or thermoreceptors, and it travels up not to the somatosensory cortex, but primarily to the insula, and from the insula to other aspects of frontal lobe, to other aspects of an affective social kind of network, to the interoceptive system. And it is typically activated to a speed of activation around 3 centimeters per second. So it's not something that either too slow or too fast, is a sort of mid-range that tends to create that nice response, okay? It's linked to the interoceptive system, so it's a way of, some people argue, it's interoceptive touch. So because it uses the same sort of sensory pathways, enters lamina 1 on the dorsal horn, and therefore enters the same sort of area where neurons from the autonomic nervous system also enter. So goes up to the insula, and from the insula goes to other parts, for example, of the orbital frontal cortex, and therefore gives that sense of pleasant reward, feeling good. So it's a sort of an important sort of reward mechanism as well. Now, the insula, and Craig argued that the insula is closely associated with the sense of self, because some people say that the insula forms an affectively felt self for the body. So here, if we're talking about the self, we're talking about touch playing that important role. Of course, we're talking from a neurophysiological perspective. We're not sort of bringing the other dimensions of the person, but it's still important to understand. In this paper from 2017, we proposed that actually, based on animal studies and so on, that probably one could argue that there is probably an homunculus in the insula that represents the body this way, where you tend to find that the upper part of the back and the head having a bigger representation than other parts of the body. That might explain why the treatment or the sort of touch-based interventions in parts of the body like the upper back or the head tend to be more pleasant than something in other parts of the body, for example. Might be something that gives us an insight of why some forms of technique work. Who knows? Now, we tried to, back in 2019, we tried to sort of investigate this to see actually what is the role of CT fibers and what's the role of this affective touch in a population that is arguably devoid from a lot of priors, which are the preterm babies. So we did a first very basic study with preterm babies in a neonatal unit in Italy, and we compared two forms of touch, which was static touch and dynamic touch. So here's this representation of the study itself, and was sort of looking at some autonomic markers, including oxygen saturation and heart rate variability. Let's see if we can see here this very quickly. This is the form of dynamic touch. So here there is not a treatment. This is purely a study, a physiologically based kind of study. No, it's not an osteopathic intervention or whatever you want to call it. It's just dynamic touch delivered through the whole back of the baby. with the hand at room temperature. That's also an important aspect, and delivering the touch at that speed of approximately 3 centimeters per second, more or less, okay? And, if we watch this for a little bit of time, we can see that after a while, the baby starts sort of, seem to be sort of liking it, seems to respond very well to this. Now, we compare this to another intervention that was just putting the hand and leaving the hand there for a little bit of time, okay? Okay. And this one here is just, just put this for a little bit of time. So what you can see here on the static touch is just basically hand is there. There's no movement whatsoever. Now, the interesting outcomes on this very basic study, so was the first of all to try to understand what was going on, and was done with, colleagues from the affective neuroscience department at the University of Liverpool, John Moores, with Francis McGlone, was to try and to understand actually what happens. And we noticed that we observe changes in autonomic markers. We observe changes in heart rate variability, also increases in oxygen saturation. It seemed like that form of touch seemed to have to sort of affect the physiology of the baby. Now, the question is, I mentioned before that, we all have the capacity to adapt, but there are times where we fail to do that. And it is therefore important that we, through that process, and again, this is a representation of the active inference framework where, two people, the practitioner and the patient, sort of infer each other's mental states. And there's a lot of information comes through that is not, it's not something that is told by the patient, but it's something that is perceived. So we tend to find that, a lot of our patients with persistent pain, for example, tend to become stuck in maladaptive internal models, negative priors that bias their perception. Bending forward equals pain. Therefore, before I start bending forward, I already, initiate some tension that gives me a signal that is, means that I'm already in pain. So it's important to understand that, that's what the patient in front of you is doing. So what we try to do is ultimately is to introduce in those cases a concept of controlled entropy. We want to change things, and we want to change things in a very controlled manner. So we want to challenge the system, hence the idea of a controlled entropy. We try to facilitate adaptive reorganization. And, the argument is hands-on care can provide that, not in a fixing the dysfunction, but in a much broader perspective. Therapeutic relationship, therapeutic alliance centered on that communication and shared narratives and so on can do that. And active inference enables this to happen. So what we try to do here, and this is a new idea that I propose here, is the idea that intervention is largely divided in two main categories. One, deterministic or causal interventions. For example, goal-directed exercise, progressive loading, particular type of manual therapy interventions that we know has a specific outcome. And also what are known as stochastic interventions, something that introduces variability, something that is novel, something that challenges the system, something that introduces something completely unexpected. One can say that actually that's what context does. But if you're thinking about the idea of in practice, we have both the deterministic approaches, one technique or one approach, it should have this, should have this outcome. That's what evidence-based practice says. Exercise works for this, manual therapy works for that, for example. So the deterministic, there's something you can predict the outcomes versus the sort of stochastic processes. And the stochastic process, what I'm proposing here is, as you're thinking about using this variability to actually start introducing change, start sort of creating conditions where touch becomes something of a sense making, something that the system sort of, the system starts sort of calibrates, the system starts kind of, starts responding to it. So what it does, and actually through that idea of affordances, that interaction with the patient, that particular ecological niche enables you to explore things in a very creative way, I would argue. And that's largely through this idea of introducing stochastic changes, introducing something that could be just a light touch, could be something that the patient may say, well, you know what, that hurts, but feels really nice. And you kind of, push a little bit more. How does it feel? Yeah, it feels really nice. So there's sort of introducing something that does not have necessarily a predictable outcome, but it's something that introduces that idea that, that there's a sort of a process of change happening. So integrating all this stuff, and, just a couple of slides, I'm sorry, I'm quite long. The idea that what I think are kind of fundamental process mechanisms for change here, epistemic trust, really, a patient that feels really in a safe environment to sort of to tell you the story, where touch can convey, safety and salience to their problem. The idea of attention modulation through precision of priors, integrating new kind of functional states, and that can be through words, but one can argue also a lot through hands-on care, and thinking about also the idea of introducing both stochastic and deterministic kind of processes. What puts everything together is to think about that the therapeutic encounter is a very unique thing. It's an ecological medium for changes to start happening. And the affordances are those sort of therapeutic invitations. The interaction gives you an invitation to do something. And you sort of, from that infers what this does. And that is through this process of active inference, because, one anticipates what the consequences are, and the systems start adapting, attuning to that. And that anchors manual therapy as this sort of context sensitive, embodied, and, and predictive kind of approach, with a very emphasis really on a very humanistic approach to care. So thank you very much. And I'm sorry that took a little bit longer than I wanted.
Hey, no worries, George. Great talk. We appreciate it. I'm wondering if you could stay on another 5 minutes to maybe quickly answer a few questions that we've got into the chat room.
Absolutely.
Wonderful. The first one we're going to start with is from John Popovich, and I'm going to narrow this down. The point about touch hands-on being more impactful than biomechanics really stood out to him, but agree that the literature suggests this considering the effect sizes, particularly in chronic low back pain literature. That said, I'm curious, how confident can we be in saying that touch is more important than biomechanics? Is this such a statement supported by strong comparative evidence? And if you could give us a quick answer, we can go to another one then.
Sure. I would say that biomechanics are still important. And I think, biomechanics can actually, a good biomechanical explanation, when that biomechanical explanation is plausible, is a very good way of actually, through this idea of an active inference system, to actually start changing things. So it doesn't mean that biomechanics do not matter, does matter, but, has to be a plausible mechanism.
Wonderful. And here's another one. Earlier, you mentioned the role of context factors or contextual factors. How do you think they are related to the topic of active inference? And can you give some clinical examples around this?
Yes, absolutely. The contextual factors are very much linked to the idea of active inference. Examples, there's a couple of very good examples actually in a very nice paper by Ongaro and Kapchuk, published in 2019, where they exemplify the idea of a patient that's, where the bowel sounds that start, and sometimes we say, well, the patient says, I'm sorry, I didn't have anything for lunch yet. Those bowel sounds could be that system feels to be in the right place at the right time, and the bowel sounds could be sort of signs of relaxation that signal to the system that you're in a safe environment, and therefore changes already start happening, sort of return to health.
Wonderful. And here's a question that's actually from me, but often touch-based or force-based approaches are considered low-value care. and they are
Mm.
assumed to lead to dependency, lower agency, poor self-efficacy. I'm sure you've heard this a number of times. How do you address this assumption when you encounter a clinician who questions you on this?
I think the important thing is we don't think about touch as a passive intervention. Here is not just manual therapy purely as a passive intervention, but manual therapy as something that can introduce can start introducing change. So, for example, manual therapy can be used as a graded exposure therapy intervention. So, for example, the fear of movement could be in a very sort of safe environment, guided with touch and so on, introducing that. And we see that, for example, as I mentioned before, in cognitive functional therapy without touch itself. But an important thing there is the idea that the changes happen through a lived body. So the body matters there, and we can use that to start introducing things that progressively start changing a little bit of that model that may be stuck.
Okay. And let's throw another one at you. With acknowledging the phenomena of coupling, entrainment, co-regulation, what research evidence can we use to inform colleagues from other specialties, along with this amazing talk, of course?
There is on the business of synchrony and co-regulation, there is some very interesting work done primarily from psychotherapists demonstrating that, for example, therapeutic alliance is strongly correlated with biobehavioral synchrony between clinician and client. Difficult, we haven't got yet any evidence in our field. It's actually something that we are working on trying to put together, but it is a way of that idea of synchrony. When we're familiar with the idea of synchronizing a sort of body movements, could be through neurons and so on. But actually, there's evidence that actually demonstrates that synchrony also happens as a physiological level, including, for example, changes in regulation in cardiovascular activity, respiratory activity, and so on, with the synchronization between practitioner and patient. And that tends to be associated with strong alliance and strong positive outcomes.
George, we'll get you out of here on this one. There's a question, is touch simply enabling a force energy transfer? Your thoughts on that?
Yeah, that's a tough one. I don't think it is. Okay. I think, I'm happy that people entertain, if you think is a form of energy, absolutely fine with that idea. I think, it's more than that. But I think, here we're talking about concepts of physics as well. So we're talking about concepts of also resonance and so on between systems. So one can, if you want to put energy there, fine. I think, we just need to make sure we don't sort of turn something in potential, something that can be argued as esoteric. But so I sit on the fence, but I respect that could be also energy.
Very good. I'm going to, on the behalf of this group and certainly ForceNet, Professor Esteves, thank you so much. This was a really great talk. And thank you for the group for connecting with us on this summer day. And we hope to see you at our next ForceNet webinar. We're still looking for speakers, so if you have any suggestions, please let us know. ForceNet folks, do you mind sticking around? And you too, George, if you don't mind.
Yeah. Thank you. Thank you, everybody.
And George, you might want to check the chat. You're getting a lot of nice comments.
Okay.
I'm going to stop recording.